Good afternoon, everyone. So we're going to start this session on instruction course on endoscopic vitrectomy. So this session is important in a way because this is not the usual way of doing retinal surgery in our regular retinal practice. There is a different way of visualizing the retina, and this gives us another additional advantage of how to see the retina in cases where you can't. So we have few talks based on what are the instrumentation and different ways of using and different clinical scenarios where we can use the endoscopic vitrectomy. So the first talk is going to be on instrumentation, what are all the instruments which are required where we're going to do an endoscopic vitrectomy. So this is what I was talking about, how we do vitrectomy routinely. So you have a wide angle viewing system or a biome where you actually look at retina while you're doing surgeries. But when you look at these type of cases, not that usually you come across these cases, but yeah, we do come across them quite often. So in these cases, the visualization like what we have seen in the previous slide is not practically possible. In these cases, we tend to remove the cornea and do a temporary keratoprosthesis and look at the retina and do surgery and put the cornea back again, maybe a corneal transplant at that time. So for this, the disadvantage is you need to have a cornea. So if you don't have it, that will be a difficulty in getting the surgery done in these cases. So having said that, what do we need to do an endoscopy? So endoscopy is basically illumination with the camera which goes into the eye, which you'll be able to see the retina using that camera. So it's not a direct visualization like what we do, but you see it on the monitor. So what you are seeing here is a box which is comprises of a camera and an illumination. But there are varieties where you can actually add laser to this. So the one below is where you have a laser machine separately, and when you connect it, this is how it actually looks like. This is an endoscope probe which comes in different sizes. So it comes as a 19 gauge, 20 gauge, 23 gauge. So you will be able to put this endoscope inside the eye using your regular scleral ports, whether you are doing 20 gauge surgery or you doing a 23 gauge surgery. But at this point of time, we still don't have a 25 gauge surgeries. So the limitation is you will not be able to do that if you are used to doing 25 gauge procedure, but yes, 23 gauge is still a sutureless procedure which you can still do it. And the way it works is like this. So this is what usual way of looking at retina, where you have light thrown from the endoilluminator and gets reflected and comes out through the cornea. Whereas endoscopy is where the light is thrown through endoscopic probe, pass through just like an endoilluminator, and the light gets captured and comes out through the same camera. The reason why we have advantage in this is we are bypassing the cornea here. So whatever happens here in the cornea, it doesn't make any difference. You will still be able to see through the camera which you are using. So, and then when you are doing surgery, this is a surgeon and this is the monitor which is there here, where you are able to see the image and do a surgery using that. So the disadvantage of doing this is you have to look at the monitor and do a surgery, and it's a two-dimensional image. Like you said, that you are getting only one camera. And the illumination of this varies sometimes. The image quality goes down as you go down, like the size of the endoilluminator, endoprobe. So the images are better with 19 gauge because of the number of fiber optics which are compacted inside that. And if you go towards a 23 gauge, the image quality goes down because you cannot put so many fiber optics inside that. So the quality of image goes down a little. But that doesn't mean that you cannot do a procedure. You can still be able to do procedure using any of these things. And the advantage of this is you can actually look at the peripheral retina or a ciliary body. So there are curved endoscope probes which can give you access to the angle and the ciliary processes just behind the iris, where you don't have to use a pars plana. So if you are planning to do a glaucoma procedures, you might be able to go through the limbus and actually see what's happening in the ciliary body area, and even do a cyclodestructive procedure with the visualizing the ciliary processes. So that's the advantage. So this is how it is about the instrumentation. So we will go to the next topic of how is it helpful in doing a retinal detachment surgeries. So that's the next thing which we were discussing about. Okay, the retinal detachment, you know, is one of the commonest surgeries which we do in retina. And like I was talking about, these are the retinal surgeries which you can actually do when there is a visualization is good. But how does it help, whether it is endoscope? Is it only in the corneas where it is hazy? I would say no. The visualization in hazy media is definitely, most of the retina surgeons are used to, they're able to manage through the hazy media many times. But the most difficult part which most of us face is looking at the peripheral retina and vitreous base or an anterior PVRs, because you will not be able to see through the peripheral retina that easily, even in clear media. And if it becomes a hazy, then it becomes even more difficult. So we looked at a possibility of visualization in hazy media. It definitely helps in identifying a peripheral problem. So this is a case where we had a corneal haze and we could not see through, and used an endoscope to see what's happening here is a peripheral retina with a hole which is formed there. Sometimes ultrasounds might not pick up these things. Looking at the vitreous base, if you look at it, so see how you are able to see the vitreous here better than what you usually see in case of a regular visualization. This is an advantage because you are looking at vitreous at a different angle. So if when you were used to doing retinal surgeries, if you change your light pipe direction, you are able to see the vitreous little more clear. So that's the advantage which you get while doing an endoscopic vitrectomy. It might appear that you are able to see more vitreous, but it's not more vitreous, but able to visualize that better. And if we see here, the vitreous base is seen, and you can shave the vitreous base more complete using a endoscopic vitrectomy. So that's the advantage, and this has definitely helped us in improving retinal surgery, even in clear media many times. And anterior PVR, so this is a case of an anterior PVR where you can see the retina is pulled up here, stuck to the ciliary process. So this view using an endoscope is not going to be easy while we are doing a regular retinal surgery, even in the clear media. So you can actually go there and dissect it out. But the disadvantage here is you have to do it using one hand, but you don't have an option of doing a bimanual surgery in these cases, because the endoscope will be fixed in your one hand, so you don't have an option of keeping it like a chandelier which we use, and use the two hands to dissect that membranes. So that's a disadvantage, but then the visualization is definitely an advantageous thing in this. The other cases is something like a microcornea. So if you look at this 3 millimeter microcornea, so when we look at this using biome, if you see the distance between the limbus and this ports is same, but from the center of cornea to this, the ports is going to be less. So whenever you put a lens or a biome, you may be able to see the central portion well, but if you want to rotate or you want to move anything to see the periphery, So this is the case where we had a nucleus drop and there is a peripheral retinal detachment. So when it's in the center, you'll be able to see. The moment you try to see, why is it, the image is going out of the view? Because the lens gets moved. So you can't see that periphery. So that's when we shifted to an endoscope, and then that problem will not be there. You are actually able to see the thing pretty well, and you don't have a difficulty in seeing what you are cutting, and then you will be able to do a better surgery. And this case, when you see here, these are the membranes which are there in the periphery, which were able to dissect well using an endoscope. So that's the advantage of using an endoscope, especially in this small corneas. So the pearls in doing endoscopic vitrectomy, this definitely takes a little longer learning curve, but at the same time, the lack of stereopsis is not helping us anyway. But when we look at the things which we cannot see usually, and we are able to see them better, would help us do a better job than what we would have done with the regular visualization. So that's in short about how we do it in a retinal detachment surgery. I'll call upon Dr. Puneet Gupta, who is going to talk about how do you use in trauma, and he'll show a few case scenarios where you can actually see how does it help in doing trauma. All yours.
Sorry.
Yeah, you can see.
No, I think that was better. नहीं वो भी तो चल रहा था ना. It's coming. Yeah, good afternoon. Thank you, Dr. Rajiv, for giving this opportunity to speak in this instruction course of, I'll be talking about the endoscopic surgery in ocular trauma scenario. So why do we need endoscopy as an option in trauma cases? What are the advantages and disadvantages, and what are the issues of endoscopy in this situation? I'll be talking about three scenarios: open globe injury, intraocular foreign body, post-traumatic endophthalmitis, and will also be touching upon delayed cases and diagnostic role in scenarios of ocular trauma using endoscopy. Iris trauma, corneal opacification, bleeding in the anterior chamber can cause restriction or obstruction of view of the intraocular structure in ocular trauma patients. Adequate surgical view is not possible with the conventional way we are operating with an operating microscope. So we need something to bypass these obstructions, these opacities, to make our surgery work. There are two options we have. First, we have temporary keratoprosthesis, and the second is endoscopy. In temporary keratoprosthesis, the binocularity and stereopsis is better, and you can perform bimanual surgery using temporary keratoprosthesis. But there are some issues like that you need donor cornea. Longer operating time is there because of you have to suture this keratoprosthesis. Because of the open sky situation, there are chances of developing suprachoroidal hemorrhage and chances of graft failure because of the inflammation and silicone oil in the eye. You may also require help of an anterior segment surgeon, and sometimes, in some situations of ocular trauma, this watertight fixation of TKP is not possible in some situation because of the wound situation. The advantage here is the endoscopy, you have lesser surgical time, and that's why there are lower chances of developing proliferative vitreoretinopathy and retinal detachment. Severe trauma to the iris, lens, chorioretinal damage, intraocular hemorrhage, all these things may lead to proliferative vitreoretinopathy, and that may become intractable if it is not treated in time. The endoscopy allows early exploration of the intraocular structures in early intervention in trauma cases, and thereby it lowers the chances of PVR and retinal detachment. There is lesser surgical time. It is beneficial where TKP, temporary keratoprosthesis, cannot be used and the graft is not available. The one more advantage with endoscopy is that you don't require to indent the sclera to visualize, because in some in trauma cases or other vitreoretinal surgery, you need indentation to see the peripheral retina. But in endoscopy, you don't require indentation. That is an advantage. And this is very important because of the wound situation in these trauma cases. But there are some advantages and disadvantages with endoscopy. The bimanual instrumentation is not possible with endoscopy because one of your hand holds the endoscope and you have only one hand to perform the surgical maneuvers. There is lack of stereopsis and binocularity. The view is two-dimensional and you are seeing things in front of you on the screen. You are not seeing through the microscope, you are seeing in front on the screen. So there are issues of shifting perspective. Their depth perception is also difficult with endoscopy. Another problem with endoscopy is that the view is tunnel-like. It depends which gauge of endoscope you are using. The view may be 125 degree or 145 degree, whether you are using 23 or 20 gauge of instrument. Another irritating issue with endoscopy is that the focusing is controlled by the assistant. The control of focusing is not in your hand completely. Rotation of endoscope causes rotation of the field of view, and there is a definite learning curve with this procedure. Cost and availability of equipment is also an issue. But the endoscopy allows procedures that were not possible with microscopic view. So that is a major advantage in spite of all these issues and disadvantages. Intraocular foreign bodies are frequent in ocular trauma, and they need early intervention due to the toxicity issues. If intraocular foreign body is lying there for long, there are chances of developing sidrosis, calcosis, and there are possibilities of developing infection also. Delayed surgery may lead to encapsulation of the foreign body, making its subsequent removal difficult. Endoscopy allows early intervention, and endoscopic assisted vitrectomy is a valid alternative in these kind of situations. In post-traumatic endophthalmitis, we all know that EVS study confirms the benefit of early vitrectomy in endophthalmitis. Anterior segment opacities due to trauma can often limit the standard vitrectomy for endophthalmitis in these patients. Endoscope is useful in such situation to perform early vitrectomy. Another advantage of endoscope is that it helps in visualizing the anterior structures like ciliary body, which is often covered by inflammatory membranes in this endophthalmitis situation. So it helps in removing those inflammatory membranes from the peripheral areas. Endoscopy is a useful tool for diagnostic in trauma cases. We all know that ultrasound has varying sensitivity and specificity in picking up intraocular foreign body and retinal detachment. It varies from 70 to 85%. L.V. Prasad, Dr. Rajiv and his group has done this study, and it says that endoscopy ensures immediate diagnosis on table, and unnecessary procedures like keratoprosthesis and keratoplasty can be avoided. Prognostication of final visual potential is a very important dimension in management of ocular trauma. Endoscopy, by allowing a direct visualization of intraocular structures, gives a better prognostication to the operating surgeon as well as to the patient to assess the prognosis. I'll show you a small video of a patient who was 41-year-old male patient who sustained injury with an iron particle. Vitrectomy for intraocular foreign body removal was attempted 18 months back in this patient, but this patient came with secondary glaucoma, total cataract, and sidrosis. CT scan orbit was performed, and intraocular foreign body was found at anterior ciliary area. This is a small clip of the surgery. Cataract was removed in an attempt to cataract was removed, and it was the conventional view was tried to locate the foreign body, but it was not located on operating microscope view. So endoscope is used to visualize the intraocular structures. This is the cut edge of the vitreous through the endoscopic view. This is optic nerve and posterior pole, which is normal. This is the cut edge of the vitreous of the previous vitrectomy that was done. I am trying to locate the foreign body which is lying at the anterior ciliary body area. This is the foreign body lying at the anterior ciliary area. Now, with the help of the magnet, I'll try to pick and lift this foreign body from the surface of the ciliary body. But because of the adhesions, the foreign body is not coming with the intraocular magnet. So the cutter is used to remove the adhesions around it, and then with the help of intraocular magnet, the foreign body is lifted. But while lifting the foreign body and removing it, get stuck at the smaller size of sclerotomy. You can visualize this foreign body is stuck. Now with the help of blade, the sclerotomy is enlarged. In this process, the foreign body falls again on the posterior pole. Now with the help of this intraocular magnet, the foreign body is removed. So this procedure was not possible in the earlier surgery with the conventional microscope, but with the help of endoscope, we could remove the foreign body from the eye. Another common situation, which is also very useful in trauma patient, is doing diagnostic endoscopy. This is a small video of a patient who was referred to me for diagnostic, for evaluating the posterior segment. This is the endoscopic view of the patient who had corneal opacity because of the trauma, and you can see the peripheral chorioretinal atrophy and fibrovascular scars. The optic disc is normal, the posterior fundus looks normal on endoscopy. So this patient can be taken up for keratoplasty. If you see that the disc and retina is reasonably healthy, then these patients can be taken up for the surgery, because sometimes you cannot visualize actually the finer things on ultrasound, and also the disc can also be seen very big. This patient was operated by Dr. Abhishek Kitari at Jaipur. Keratoplasty was there, and this is the final picture of the retina that we saw. The patient regained vision of 6/12. So diagnostic use of endoscopy is also very useful in ocular trauma patients, so that we can choose in which patients we can perform penetrating keratoplasty with a useful vision. So in conclusion, the endoscopy has certain advantages over TKP and the conventional surgery. It allows early intervention, lesser surgical time is there are lesser complications. It provides more time for the surgeon to find useful corneal graft for the implantation. The post-operative inflammation is less severe after endoscopic surgery if you compare with TKP. But there are some disadvantages and difficulty. There is a quite steep learning curve, lack of stereopsis, limited field of view, and difficulty and inability to perform bimanual surgery is an issue with this, and the cost of equipment is also an issue. But whatever you say, the endoscopy allows procedures that are not possible with microscopic view. It is a very useful equipment in vitreoretinal armamentarium alone or as an adjunct to conventional method. Thank you very much.
Thanks, Punit. That's an interesting talk on trauma and how to use an endoscope. While I'll ask Dr. Modit to go ahead and give his take on diagnostic endoscopy, using an endoscope and using for diagnosis of some conditions, which might help us in managing the patients better. While he's setting it up, if there are any questions, we can take now. So Puneet, what do you think is the reason why there is less uptake of endoscopy in retinal practice?
I think there are two, three main issues. First is the cost of the equipment and the recurring cost of the equipment. And another technical point, if you see the view of the endoscope, there are the limitation of the view. Because of the tunnel-like view and lack of stereopsis, and you are not able to perform bimanual surgery, there are some limitations. Because of those things, the learning curve is very high, very, very steep. That may be the reason that people are not taking up this very useful modality, which is, I have seen in my experience, has helped in a lot of patients, which we could not have managed with the with conventional operating microscope system. I think the cost and the quality of view is an issue, but I think with the coming newer techniques and some newer innovation, these issues will be solved in future.
Yeah, Dr. Puneet, great presentation. One question that I asked, or that I wanted to ask is, the video that you showed had a largely clean-looking vitreous cavity, but often in trauma, we are faced a situation where you put in the endoscope and then smack, you have the hemorrhage right there in front of the camera, and only thing that you see is bright red light and no details whatsoever. So how do you approach in those
Actually,
situations?
it is said that with endoscopy, you can perform procedure relatively earlier, but if there is active bleeding, I think it is impossible to do surgery even with any view. So you have to wait for a couple of weeks to get the hemorrhage or things organized. Only then I think you can. Dr. Rajiv, what is your?
What I usually do is try to clear the anterior vitreous. Most of the times, unless there is a complete no view, you might still be able to see some amount of anterior vitreous, and then you can actually remove a little bit of an anterior vitreous where the blood and everything is there. And moment you start seeing your endoscope with the cutter inside, so that's the time when you can actually go ahead and start using an endoscope to clearing it. What I usually do is a external clues. So when I'm doing with endoscope, I go with an endoscope towards the active port, that is where my cutter is, where I'm entering in. So that means I'm directing my endoscope probe towards that port where I'm entering in, and the moment you go inside, you'll be able to see that cutter there. Most likely you will have a clarity there, and if you have done a little bit of anterior vitrectomy there, it gives you a area where you can actually see the cutter. And once you start seeing that, go extend it along with that. So don't let the view of the cutter be lost. So that's the only clue which I would say which can help you to do that. So I don't wait for 2 weeks, I go ahead and do it earlier. Go ahead, Mudit.
All right. So good afternoon once again, and first of all, I would like to thank our Chief Instructor, Dr. Rajiv Reddy, for making me a part of this instruction course, and also for teaching most of us the nuances of endoscopic vitrectomy. And also I would like to thank the AIOS Scientific Committee for giving us a chance to present this work. So I'll be speaking predominantly on diagnostic endoscopy as to how endoscopy can be a valuable tool in prognosticating these eyes. So if you look at these eyes, these are eyes of failed graft, corneal scars, post-keratoprosthesis, where sometimes prognostication is difficult. How do we go around treating them? Should we go with a repeat graft, or can we leave these eyes like that? And if you look at it, a lot of times while the B-scan may help us in assessing the fact that the retina is attached or detached, it does not give us much of a knowledge about the structural integrity of the retina, how the retina is, how the disc is. So those are some of the parameters which a B-scan will not be able to reveal. And that is where a diagnostic endoscopy comes into picture. Dr. Puneet had earlier shown in his talk a case where post-trauma they had gone ahead and done a diagnostic endoscopy and visualized the retina. So this is how a diagnostic endoscopy setup helps us. What it helps us is it allows us to assess the retina as well as the optic disc, and can help in a better prognostication in these cases where a conventional ultrasound probably may not be much helpful. So these were some of the other images. This is the patient with a corneal scar, while a B scan does reveal an attached retina. If you look inside, you go and see an absolutely glaucomatous optic disc with sclerosed vessels. This is not an eye which is likely to benefit from any further intervention. Same holds true the next case, a case with a keratoprosthesis, where while we do see a detached retina, you may think that we can go ahead, probably do a repair, but an endoscopy allows us to visualize the fact that it's an extensively necrotic retina, where it will not probably yield a much of a visual prognosis. Another case with a failed graft where we see a retinal detachment, and an endoscopy gives us a visualization where we can see it's a closed funnel RD with extensive membranes. Again, a case for a poor prognosis. So these are cases where endoscopy allows us in prognostication. So thereby, by allowing us to prognosticate, it can help us in a more judicious use of these corneal allografts and more judicial use of a corneal reconstructive procedure subsequently. So if you look at it, this is how the endoscopy system is. This is the E2 laser endoscopy system by Endo Optics. It allows us, unlike a conventional vitrectomy which gives us an end-on view, over here, a diagnostic endoscopy gives us an end-on view, unlike a conventional which gives us a bird's eye view. So what you see over here is this is your endoscope camera, and this is the area which you can subsequently visualize. My slides are stuck somehow. So let me just show you how an endoscopy works over here. So this was one patient with an opaque graft, but when we went inside, we could visualize the fact that the retina was attached and the disc was healthy, and this was a patient where we could subsequently go ahead and do a repeat surgery. Same holds true for this eye. Once we did an endoscopy, we were able to visualize the retina, which was absolutely healthy, and a good healthy disc. So these are cases where a diagnostic endoscopy allows us to visualize the structures which are not clearly visible. This is a video courtesy my co-author of and co-instructor in this course, Dr. Vivek Dave, and endoscope also allows us, apart from that, to visualize angle structures and in some cases an occult foreign body which may be stuck. So these are some of the advantages which an endoscope affords us, allowing us to visualize areas which were till now not accessible or amenable to a conventional visualization system. So this was a foreign body stuck in the angles, and with the help of an endoscope, Dr. Vivek Dave was able to visualize it and also helped in its removal subsequently. So these are some other cases where an endoscopy allows us visualization of ciliary bodies, allows us to visualize membranes and do a PVD and complete surgery. Membrane peelings can be done. Peripheral retinal detachments can be assessed over here in these cases. So peripheral retina detachments, peripheral breaks, all of these can be assessed with the help of an endoscope. And this is something which we have tried to initiate. We tried to start having a form where all the surgeons who did an endoscopy could document the data regarding the structures which were visualized, including the angle structure, ciliary body, posterior surface of iris, and posterior segment findings. So we did also analyze these results and found out in a paper which we had published the fact that an endoscopy allows us to visualize these areas, and these were the indications, penetrating trauma being the most common one, and pale disc and sclerosed vessels were commonly analyzed. Apart from that, advanced glaucomatous cupping, scarring in a few of cases, retinal scarring, hemorrhages, and choroidal detachments were the findings which we assessed with the help of these in all of these cases. In fact, when we tried to compare with an ultrasound, we found that an ultrasound was able to pick up it in 23 cases, but there was one false positive. And there were 3 cases where there were false negative on an ultrasound. So endoscopy helps us in better assessment of these structural abnormalities, which probably we might miss with conventional ultrasound. And thus, I would like to just conclude by saying that it also helps us in better utilization of further corneal reconstructive procedures and in allowing us to visualize these structures. And with that, I would like to end my talk, and thank you once again for a patient hearing.
Thanks, Mudit. Any questions? If not, I'll have one.
Tell us about the learning curve,
Yeah.
because it's so different from regular vitrectomy. When we see, under the microscope, the learning curve, I'm worried about how long it takes and to be a good endoscopic to do it well, what do you have to do to?
Yeah, so like I said, What we do in a conventional vitrectomy system is we've got a bird's eye view where you can look from above and you can see the visualized structures. An endoscopic surgery has got an end-on view. So it takes an initial learning curve. You may probably need at least 5, 6, maybe more surgeries. But the important point is like what our earlier instructors had told about, Dr. Rajiv had said, Dr. Puneet has mentioned, and probably Vivek also will be talking in his talks about the fact you need to, once you get the hang of how to insert your instruments and how to follow your instruments once your probe is there, and to follow up the cutter and visualize it, then over a period of time you do get a hang of it. So while there is an initial learning curve which is involved, it is not a difficult skill otherwise once you get the hang of it. And it becomes extremely valuable in management of your cases.
I'll
Best way to learn endoscopy initially is to use your endoscopic view endoscope in your normal routine vitreous surgery also. You can use your endoscope for illumination, and simultaneously you can view structures in front of you on the screen, but you can perform surgery through endoscope. So initially you get hang of it, how things are visualized with endoscope. So that is the way I started.
Yeah, while Vivek is setting up, I'll comment on that. So when I started, the first surgery I did was with endoscopy to do a surgery straight away. So I could manage to settle the retina without having a problem. So having said that, it's not going to be easy. That's the first surgery. Like you can say that it's a beginner's luck, but it did take a long time for me to be little safe, I would say. So what I did was I used to like what Puneet was talking about, maybe use it along with where the visualization is good. And two is I used to do a diagnostic endoscopies. That's how we publish that paper first. Whenever we are planning to do a keratoprosthesis, which is going to be an extensive procedure, we started doing a diagnostic endoscopy and then started going ahead doing that procedure only if there is a good visual potential in that. So that got me used to it. So that gave us another question which we wanted to answer. How about the learning curve which you were talking about? So Vivek actually had to look at different videos which we have recorded over a period of time and see what the learning curve is going to be. So he would be in a better position
If
to
time
answer that.
permits, I will show you a graph.
Okay. So Vivek is going to talk about management of endophthalmitis using an endoscopic vitrectomy.
Thank you, Rajiv, and thank you, AIOC, for giving us this opportunity to present some of our knowledge regarding endoscopy. I'll be speaking on endoscopy in concurrent corneal infections and endophthalmitis. No financial disclosures here. An acknowledgement to Rajiv, from whom I have learned the tricks of the trade. If we look at current literature existing with respect to corneal infections and endophthalmitis, there are a lot of papers out there. If you put together the gist, what we come to know is corneal ulcer or keratitis associated endophthalmitis forms a small chunk of endophthalmitis in general, around 1 to 2% only, but around a third or more of those do not reveal any organisms, and only about 3 to 4% actually reach a visual acuity of more than equal to 20/50. Most importantly, literature will tell you that evisceration rates vary from 1/3 to 2/3 of those cases. If we turn it the other way around and look at risk factors for endophthalmitis that require evisceration or enucleation at the end, we find that corneal ulcer related endophthalmitis is a very high independent risk factor. So what does it tell you? You may not commonly get keratitis with endophthalmitis in your practice, but if you get that, 1 in 3 or 2 in 3 chances that you are going to lose the eye. So that tells you how important this subset of infection is. Now mind you, this is Western literature. When you think of it in the Indian setup, we are a tropical country, we are a country where infections are high. These numbers actually vary and you will find a higher footfall in your clinic in this subset of patients. So often these are the scenarios. This is what the cornea looks like and the posterior segment is infected. As Dr. Puneet told you in his presentation, you have that standard option of doing a keratoprosthesis, very laborious surgery, have to bring in a cornea colleague. After doing everything, if you see that there is no prognosis inside, you still can't stop there. You still have to remove the keratoprosthesis, replace the eye with a graft. If things do go fine and you have put in a graft and have managed to take care of the posterior segment, you have still made that patient a post-PK patient for life and have missed out on that chance of possibly the keratitis healing with a natural scar. So we go to some case scenarios and try and see how we fit the usage of endoscopy in endophthalmitis. So my first case is a 9-year-old female, history of trauma with a wire 6 days back when she presented. Previous corneal intervention done elsewhere 3 days ago where the corneal tear was repaired. Visual acuity presentation PLPR accurate. This is what the eye looked like. You have a repaired tear with an infiltrate around it. You have an immune stromal ring. It's immune because the edge of the so-called infiltrate is not reaching the limbus. You have the posterior segment which is showing echoes throughout the vitreous cavity. So this patient in the emergency setup underwent a vitreous biopsy procedure, and in 24 hours we saw growth, and the growth was then characterized to be Enterobacter species. So what do we have here? We have a post-trauma etiology, we have a gram-negative organism, we have a young patient, we have no posterior segment view. Given the first 3 points, there is adequate literature now to suggest that if you clear off the vitreous cavity adequately, you are likely to have a better chance as against only injecting this patient. Now, because we had no view, we approached this patient endoscopically. Herein you see that the endoscope goes inside and all these dense exudates are cleared out very conveniently with the endoscopy probe as shown in the video that is playing. We clear off the vitreous and reach the retina right down. We see some amount of cystoid macular edema, but otherwise the retina per se is attached. Some amount of fluid air exchange and intravitreal antibiotics. Now this is what we are left with. So think of this way, if we did not have an endoscope and we wanted to clear the vitreous cavity, we would have made this patient a post-PK patient for life. Now this is a child. Instead, what we have found is, after having taken care of the posterior segment pathology and treating the cornea medically by our cornea faculty, you end up with a really small scar wherever the injury was, and rest of the cornea was just an immune reaction which has settled down. And this patient, this is what the retina looked like. Yes, there is ischemia, there is effect of infection, but a reasonably good vision of 6, 18 and 12. Second case scenario, 12-year-old male, decrease of vision in the right eye since 4 days, pain watering and history of injury with a needle prick. Again, a PLPR inaccurate was the presentation. You see an epithelial defect and a small infiltrate with a small curvilinear tear there if it is visible on the screen. There is again an immune stromal infiltrate that is seen, posterior segment showing echoes, membranous as well as dot-like involving most of the posterior aspect of the vitreous cavity. This again grew organisms, turned out to be Enterobacter aerogenes as a significant growth. This patient also underwent an endoscopic procedure to clear out the vitreous cavity in view of inability to see through the current scenario of the cornea. Herein we see all these dense exudates are being cleared out, and we were again able to successfully reach the retina. We could see a lot of necrotic areas on the retina, and appropriate antibiotics were injected. As the patient also had necrosis inside, in my practice I tend to use silicone oil in such cases. So this I underwent a silicone oil injection at that time. So this is what was the pre-op presentation. This is what is the post-op presentation 2 months down the line. Again you see that cornea has cleared out very well, and this is what the retina looks like. Again, the vision is not great, but counting fingers 3 meters in the given scenario of presentation, I think all of us would accept it as against losing the eye. Scenario 3, now this is an interesting one. 52-year-old male, reduced vision in the left eye along with whitening, progressive since the last 4 weeks, very poor presenting visual acuity, was on topical antifungal and antibiotics, was advised evisceration at a couple of places elsewhere before the patient came to us for another opinion. Now, the advice of evisceration, if you look at this scenario, would also cross all of our minds. The cornea is melting, the periphery is vascularizing. If you look in the center, it's almost like a decimetocele, and the posterior segment again has dense exudates. We see a stromal infiltrate, we see extensive central thinning, and we also see a hypopyon. So in the emergency room at our institute, a tissue adhesive with a bandage contact lens was done to maintain an immediate globe integrity, and this patient was then referred to the retina services for intervention. So when this patient came to me, I took the patient up but was not expecting much inside. I thought, just like what Mudit has shown, we would possibly go inside, diagnose that everything inside is completely knocked out, and we'll have to explain a poor prognosis to the patient. But see what happens. You go inside, you clear out the vitreous as shown in the previous videos. Now this is an edited video. I'll take you right to the last step. And when you go inside, you see that the retina is not really bad at all. So one learning here was the B scan may sometimes overestimate the amount of damage in the posterior segment of the eye. We immediately had our cornea surgeon come on table and replace the infected cornea with a clean graft. This is what the patient was 1 week post-op, 1 month post-op, and at 3 months with a vision of 2200. So 3 months pristine looking eye, 2200 vision in a patient who otherwise may have gone ahead for an evisceration if we would have thought conventionally. Last case scenario, this is fresh off the OR. This patient presented to us in January as a part of cluster end off in a different state, was referred to us, has had multiple intravitreal interventions done. The culture locally before referral has turned out to be a drug-resistant pseudomonas. The eye is what it looks like: severe corneal edema, posterior stromal infiltrates. I'm sorry, I don't have the B scan, but the B scan showing dense exudates and a possibility of a retinal detachment, which we could not really figure out clearly. We intervene into this patient again endoscopically because the cornea doesn't allow you visualization. You see dense exudates there. The cutter goes in, is entangled in all the dense exudates. We clear the exudates off, and as we move towards the posterior pole, again a sort of partially necrotic looking retina. And just look at the right side of your screen there. If you would have seen, there was a break there, and that was what was causing the B scan to be something like a retinal detachment. Now that we have a retinal detachment, you are obligated to do a complete vitrectomy. So meticulously, the entire vitreous was removed to the extent possible. After having done the vitrectomy, the retina is being settled here under perfluorocarbon liquid. And after having settled it down, we examine all around, and wherever we find areas which are looking very thin or which are looking break-like or sieve-like, undergo laser. So this is, you are seeing that break is getting lasered, and also a 360-degree endolaser was done. Peripherally, there were certain suspicious areas which we could not confidently reach with laser, and those are the areas which underwent peripheral cryo. So done and dusted, January, retinal detachment settled, eye filled with silicone oil after a fluid air exchange, and the patient is then being kept on a continuous follow-up. So this is what the eye was subjected to, that is silicone oil injection. Now we cut to just about 2 weeks, 1 week ago rather. So this is now where the eye is. The infection in the anterior segment has settled down. You are left behind with a corneal scar. You are left with an eye which is now quiet, and the posterior segment is filled with silicone oil. Obviously the B scan would not give you what is the retina looking like. So this is the point at which you are now doing a rehabilitative intervention. The cornea guy comes in, removes the cornea. You can see that there is a decent glow which is visible. Stay sutures go in, and you then remove all the oil and then get your first opportunity to actually see the retina conventionally. View is hazy because the graft is not completely clear, but as you can see, the retina is very well attached, though ischemic. I go ahead and do an additional row of peripheral barrage laser just as a part of additional security, and the cornea person comes back in and puts in 16 sutures. So because this was just a recent case, that is why I cannot show you further follow-up, but day 1 post-op, we had again counting fingers at 1 meter. We have summarized our experience in this paper, where we have found in our setup the evisceration rate as against 30 to 60% in literature has come down to 3%. We have also put across some more literature where we have shown the effect of using endoscopy in these cases and how it helps us avoid unnecessary keratoplasties, and also the fact that if you do a clearance of the posterior segment right away and then plan a delayed keratoplasty sometime later, you are more likely to have the graft surviving as against going ahead with a temporary keratoprosthesis and an immediate graft. There is also a good article from our group as a review for anyone who would be interested in learning the overview of endoscopy. In conclusion, microbial keratitis with coexistent endophthalmitis is an uncommon but a grave clinical presentation. Aggressive management is warranted to achieve globe salvage. Conventionally, posterior segment access can be achieved by a K-Pro or a keratoplasty to allow for a PPV. Endoscopic approach circumvents the necessity of such a labor-intensive approach, also allows for the natural resolution of the corneal opacity in appropriate cases, and thus avoids unnecessarily keratoplasties in eyes with a poor posterior segment. So thank you very much for your kind attention.
Thank you, Vivek. That was an excellent presentation and excellent videos which showed us different scenarios of endophthalmitis and definitely helped in saving many eyes than what we would have without it. Any questions? Okay. So, if not, I'll have one question. What's your usual practice now? Did it change your practice? Like, if suppose you see a corneal ulcer with suspected endophthalmitis, so would you go in and start doing vitrectomy using an endoscope, or how is this endoscope changed your way you practice an endophthalmitis with keratitis?
Yeah, I think that's an important question. Right now, so we do not have adequate literature proof that either we have generated in-house or that's available in literature which would help us differentiate which cases of an anterior segment infection with a coexistent end-off would you necessarily intervene, or which cases would settle down with, say, just an intravitreal injection. So I have made certain rules of thumb for myself in my practice. In conditions where you saw those two cases, they had an immune stromal ring. So an immune stromal ring actually is a toxic reaction on the cornea and very commonly seen in gram-negative endophthalmitis. So you will find the edge of the ring does not reach the limbus. So if that is one of the clinical presentations, then my threshold to enter endoscopically is very low. So that is when one would enter. So possible potential or a proven gram-negative etiology. Second is an ultrasound which shows a definite retinal detachment, or my suspicion of retinal detachment is high. And third is in a situation where the drug sensitivity profile is showing a multi-drug resistant organism. So these are the three subsets where I feel it is very imperative to have an adequate vitreous clearance. Having said that, like I showed you in one of the cases, B scan sometimes can overestimate. You may feel it's an infection, it really may not be there. But I think with adequate experience, you surely can enter those eyes, not really do much harm by clearing off the vitreous cavity in a scenario where you have possibly overdiagnosed it. So I think even if you end up doing a few extra endoscopic procedures on the assumption that the posterior segment was infected, it is fine as far as you have your sets defined where you would like to go in and clear out the vitreous.
Thank you. Any more questions from anyone? If not, I'll conclude with the message. The endoscopic vitrectomy, like we discussed till now, is a definite addition to whatever armamentarium which we have for doing retinal surgeries. The downside is the cost of the instrumentation and recurring cost of a probes. But there are ways of getting that cost down, and long learning curve is something which most of the VR surgeons are used to when we started retinal surgeries. that should not be a major limiting factor, but it's going to be in addition to whatever we are doing. So that's, I would say, the take on endoscopic vitrectomy at this point of time.
What's the cost like? The equipment?
The machine would, in Indian rupees, it will be costing somewhere around 40 lakhs. And the probes, each probe will cost you around 2.5 to 3 lakhs. And those are the ones which will create a problem, because because of the thin probes, we tend to get damaged, and then we may have to keep buying them often.
How many procedures you can do with the probe?
I have not looked at an exact number, but we can easily do 40-50 procedures. Okay. It all depends on how you handle them again. So any endoscope probe, it's a reusable one. It's not like a disposable one anyway. So if you handle them well, and if one person handles it well, you should be able to get it them for a longer time. But as I said, the 20 gauge probes are maybe last longer than actually a 23 gauge probes, mainly because of being fine in nature. So that's it.
There are actually two models of, there is only one company, I think, which makes endoscopy equipment, that is Endoptics, and there are two models. One is with laser, and the other is without laser. You can use your own laser, which most of the vitreoretinal surgeons already have in their OT. So that is a equipment which has illumination and view. Laser you can use separate. So the cost comes down to almost about 25. So that is one option in that. But the probe cost is really very, high.
But if you can use it for quite a few cases, then it gets divided. As you said, 20 or more cases, 40 cases.
Yes. It's as I said, it's a reusable one. It depends on how long and how you are going to maintain it. But it definitely adds a value. Okay, that concludes our session. We have a keynote lecture today. Our keynote lecture guest is Dr. Niaz Abdul Rahman. He is a well-known vitreoretinal specialist from Bangladesh. He is well experienced. He's going to talk about nuances in diabetic vitreous surgery. Dr. Niaz.
Thank you very much. I'm grateful to the organizing committee, and especially Dr. Partha Vishar, who sent me a mail saying that, invited me for this keynote lecture. Well, I'm going to talk about diabetic vitrectomies. Although we've just heard about endoscopic vitrectomies, that's for vitrectomy, that's at the one end of the spectrum, the higher end of the spectrum. Well, I'm going to talk about diabetic vitrectomies that all vitreoretinal surgeons are familiar with. Now, when we start doing our fellowships in vitreoretina and start learning surgeries, the first kind of surgery that we sort of learn are retinal detachments. And gradually, as we progress, we sort of master regular retinal detachments. And then we move on to like macular surgeries. First, we think that peeling the ILM would be a very difficult job, but soon we find out that it's not all that difficult. We can do it. But what we really have to learn are the complex surgeries, especially with the detachments when there is complex RDs with PVRs, and then the diabetic vitrectomies. Once we start doing diabetic vitrectomies, we find that it is fun. Actually, it's fun to do diabetic vitrectomies. And there are certain learning curves, but it is quite gratifying, and it also tests the skill of the surgeon. And for PDRs, what I want to say is that most patients do benefit from PDRs. And PDR surgery allows, requires us to understand vitreous hemorrhage and all the membranes and what is going on in the eye in proliferative diabetic retinopathy. One point of note is that in spite of good treatment like anti-VEGF and PRP lasers, many of the patients eventually need surgery. So surgery is, we need to do surgery because PRP is not the end of the treatment, because the process keeps going on in their bodies. This case, like in 2014, we saw a clear case of PDR. He got some lasers, got some anti-VEGF, but in a couple of years, he did develop all the membranes and required surgeries. And therefore, early surgery is recommended always. You must do an early surgery that gives you a lot of benefits. Now, regarding hemorrhages, you can have hemorrhages behind the posterior hyaloid phase, the pre-retinal hemorrhage. And if it doesn't break through, these hemorrhages tend not to get absorbed for a long, long time. And it's pretty easy to remove these hemorrhages. All you need to do is create a PVD and make an opening in the posterior hyaloid, and that gives you access to underneath the PVD, and you can clear out the blood very easily. And if the macula is okay, then the patient really benefits from the surgery and gets back vision. But often there is breakthrough, and then the whole blood comes into the vitreous, and if it stays for a longer time, the whole vitreous becomes very hazy. A B scan will show all the blood in the vitreous, and then the PVD, and also some blood behind. In these cases, as you cannot visualize where the retina is, the surgery can become difficult, and it's a challenge. You really don't know where the retina is. So all you have to do is look at the undulations, try to figure out where the PVD is, and make a tiny opening, and then remove or evacuate the blood from underneath the posterior hyaloid. And gradually, as you do it, you get a reflex of the retina. And once you can see the retina, you're home, because then you know where you are stationed, and you can easily complete the surgery. Well, that's about hemorrhages. But the real thing is the membranes. Diabetic vitrectomy is all about membranes. To do that, I think all of our fellows and all aspiring surgeons should understand what membranes are and the configuration of the membrane, how membranes occur. A new vessel usually is flat and remains on the surface of the retina. Soon, fibroblasts invade, and you get a fibrovascular complex, and this sticks in with the vitreous and grows into the vitreous. When there's a PVD, the part that's in the vitreous gets detached, and the other part anchoring with the retinal blood vessels gets attraction, and you develop attraction detachment. This, a young student should sort of understand this mechanism and should be able to visualize in a three-dimensional aspect, like the last photograph, of exactly what's happening in the retina. If this is understood, then you can really go ahead and do the surgery, because you understand the planes and know how to dissect. Because as it progresses, more and more membranes form and more tractions happen, and you have to get the planes and understand where to dissect and where not to dissect. Well, let's look at this case. Here the retina is still flat. There are lots of new vessels, and with anti-VEGF, most of the blood vessels have regressed, and it's now fairly easy just to pick it up with our new cutters and all. You can use the cutters as forceps, but you'll find small tags attached from the underneath of the membrane to the retina, and if the tag is along near the fovea, then you have to be very careful. Instead of pulling, you should just separate it and then go ahead and pull the membrane away. And gradually you can pull with the cutter or with the forceps and gradually remove it. And it's not a difficult job. And also you can find a plane, like I'm finding now, when there's a gap between the membrane and the retina, and the newer cutters with the tips so close to the end, you can easily dissect it without damaging the retina. The problem arises when there's associated retinal detachment. When there's an associated retinal detachment, it can be a combined, like you see the tear over there, so it's a combined rhegmatogenous and traction detachment. Then pulling the membrane away, you can also tear the retina because the retina is often very fragile. So you have to be very careful. Like you see, I've just made a tear. So if you think there is a stronger adhesion, you can circumvent it so that you leave the tag there and not tear the retina. Still, in most cases, gradually, with gradual nudging, you can remove the whole membrane and then do a fluid air exchange and settle down the retina. But so this plane, if you can understand the plane, and if you can understand how much space you have underneath the membrane or the posterior hyaloid, that is the essence of vitrectomy in diabetics. So understanding the plane, even if it's a thin posterior hyaloid or a thick membrane, the plane is the one that you have to understand. And you must have a good machine also, nowadays with high cutting rates and the port so near the tip, that gives us the advantage of doing good vitrectomies. And we can, most of the time you can peel off the membranes, but you'll find that at times there are places where the membrane is firmly attached to the retina and it just wouldn't come off, and pulling and nudging at those places can damage the retina underneath, like here. So we normally do surgery with one hand, because one hand we have the light pipe, the other the cutter or the forceps, and pulling like that can damage the retina. And these are the cases where a bimanual surgery can be really benefited. So to do a bimanual surgery, you have to have a separate port, 1 or 2 ports, to put in your chandelier light. In this surgery, I'm putting in two chandelier lights to really illuminate the posterior segment. And in one hand, I've got a forceps, in the other, I've got my cutter. So, and I know that this strong membrane has attachments underneath where I would not have been able to access single-handedly. So with the forceps, I'm everting the membrane and gradually severing the connection between the membrane and the retina, and let the retina fall back without damaging it. So that's the beauty of bimanual surgery. But it's not very often that we do it. It's not, most of the time we can do it unimanually. So bimanual is there always, reserved in cases that we want to do it. Therefore, with these surgeries, a case with diabetic membranes, with careful removal, you can really give benefit to the patients. And even if there is membrane along with traction detachments, you can relieve the detachments and give benefit to the patients. Well, the last thing I want to say is 3D viewing surgery. 3D surgery, as you all know, we have just had sessions in the morning, so I won't go into the pros and cons of heads-up surgery. But for those of you who have not done 3D surgery, especially 3D vitrectomies, I'd ask you to just go ahead and try, because the view is exceptionally good. That, I just can't get over it. The view with my regular surgery and the 3D view is exceptionally good. The resolution is so high and the depth of focus is much enhanced. So it's an entirely different experience, especially when doing vitrectomies. Over here, we use the Artivo system, that's the Zeiss system, and the photograph, this photo is obviously a two-dimensional photo. Here, everything you'll see on the screen is double because there are 2 images there, and with the polarized glasses, the 2 images fuse and you get a 3D vision. And everyone in the OR, or the fellows and the nurses, and everyone can see in 3D. But you see, this picture, this video was taken regularly in a 2D, the regular video. But here you can also appreciate the great depth and the high resolution. If I compare this with my regular photographs, like the ones that I've just shown in the previous slides, you'll notice that this has greater depth. That is the beauty of this 3D thing. So you do get a real great depth, and when you start removing membranes, in these cases, you can really get the planes and you can do a really safe surgery. That's what I feel. Like in this diabetic case, you'll notice that when with the forceps, I just lift the membrane, even in this video, you'll see the great separation that you can easily see. And in the 3D, it is much, much more enhanced. So the surgery is actually a different experience than our normal microscopic surgery because of the enhanced depth. So friends, that's all I'm going to say. Just be bold. And the timing of our vitrectomies in diabetics is very crucial. We shouldn't wait too long for vitreous hemorrhage to clear. And if there's traction detachment, especially involving the macula, or if there's combined RDs, I think we should just go ahead and not waste time. Thank you very much for a patient hearing. Thank you, Chairman.
Thank you, Dr. Rahman. That was an excellent talk about how to manage the diabetic vitrectomies. So that's one of the most difficult surgeries which any retroretinal surgeon will face, and one of the most unpredictable surgeries which we face, because when we see a membrane, you think that it's simple, but then when you go inside, when you start doing vitrectomy, then you realize it's something more difficult. And you made it so simple to look at, and then that's really good. Thank you.
Thank you.